Welcome to our channel viewers. This is second video tutorial on inflammatory bowel disease. In this video tutorial, we have talked about Crohn's disease. In the previous video, we have discussed in detail about the ulcerative colitis. Crohn's disease is a puzzling subject, and I find medical student and surgical trainees struggling with this topic to understand. We have covered in detail everything a beginner, a trainee needs to know about the Crohn disease, and we have combined theoretical discussion with a case-based discussion. I hope you will enjoy the talk. Stay tuned. So this is a real life case scenario which I am giving to you. So the diagnosis can be anything. It is not that it is Crohn disease only that we are discussing. So keep your option wide and let's start. So this is a 38-year-old male who has presented to us with history of abdominal pain for last 5 months, history of diarrhea for last 4 months, and intermittent history of non-passage of stool and flatus for last 4 months. So the main presentation is pain in abdomen, diarrhea and intermittent obstipation for last 4 to 5 months. The pain was acute in onset. It's located in the central abdomen, colicky in nature, and used to get aggravated by food. There was no history of any radiation or referral to any other site. He had a history of diarrhea, which was 5 to 7 episodes per day. It was semi-solid in consistency. There was history of loss of weight, which was undocumented loss of weight, and he also gave history of obstipation for last 2 days before presenting to the hospital, along with abdominal distension. He also gave a history of nocturnal symptom, that he used to have the aggravation of symptom during night. There is no history of fever, any GI bleed, lump abdomen. There was a history of appendectomy at the age of 13 years. On abdominal examination, the bowel sounds were increased and there was mild distension present at the time of presentation. There were no visible peristalsis, lump or tenderness. His rectal examination was normal and his general physical examination was also unremarkable. We managed this patient on the line of acute intestinal obstruction with the help of IV fluids and other conservative measures. Rice tube was inserted, and patient started showing improvement after 48 hours, and he started passing stool and flatus after 48 hours of conservative management. Friends, make your plan. What is the diagnosis? What could be the differential diagnosis in this patient? And what are the further investigation required to work up this case and manage this case in a 38-year-old male patient with history of recurrent intestinal obstruction of almost 5 to 6 months duration. So coming to the topic of this video tutorial, the ulcerative colitis and Crohn disease, there are two phenotype patterns of inflammatory bowel disease. In Crohn disease, the inflammation is transmural. That means it involves the whole bowel wall, and it occurs in any part of GIT from mouth to anus, and it is associated with development of complications such as fistula or stricture. While the ulcerative colitis, which we have talked in detail in the previous video tutorial, the link for which I will share in the description, it is superficial inflammation that occurs only on the colon. So that we have to understand from the very beginning that Crohn disease affects whole GIT from mouth to anus, and it is a transmural. That means it involves the whole bowel wall from the mucosa up to serosa. While the ulcerative colitis, it affects only colon and maybe some part of the terminal ileum that we call backwash ileitis, and it affects only superficial part of the mucosa and submucosa, and there is no transmural inflammation. So with this basic understanding, we'll start discussing the Crohn disease in this video. The Crohn disease is a lifelong disease, and it arises because the interaction between genetic and environmental factor, so that the person who is genetically predisposed comes to the susceptible environment, he will get the Crohn disease. The Crohn disease is predominantly found in the developed country, but the landscape is quickly changing. That means more and more cases we are seeing in the developing countries, and more and more patients are coming to us in the clinical practice. The precise etiology is not known, so therefore a causal therapy is not yet available. So that we don't know the cause, so we don't have any specific curative treatment. And it is unlikely that the precise pathogenesis of Crohn disease will be understood soon, because we are not getting any breakthrough despite the extensive research about the etiology of Crohn disease. And most of the facts and figures which I have given in this talk are from these consensus guidelines, that is third European evidence-based consensus on diagnosis and management of Crohn disease part 1 and part 2, and ECO ESCP consensus on surgery for Crohn disease from Journals of Crohn's and Colitis, published in 2017 and 18. So let's understand about Crohn disease activity index, because its reference will come time and again while we discuss about this disease, and in different journal also there is a mention of Crohn disease activity index. It is basically a calculation depending on different variables, that number of liquid stool per day, abdominal pain, general well-being of the patients, number of complications like arthralgia, iritis, erythema nodosum, pyoderma gangrenosum, etc., fever, and need for opiates for the diarrhea, abdominal mass, deviation from normal hematocrit, or deviation from standard weight. The Crohn disease activity index, that CDI less than 150 indicate a remission, while more than 450 indicates severely ill, that is a very severe disease. There are many online calculators available for calculating the Crohn disease activity index, and MDKL is one of that type of online calculator, where we can simply input the values, and online we can calculate the Crohn disease activity index. So for the purpose of trials, most clinical trial will recruit patient with Crohn disease activity more than 220. Remission, as I said, is widely accepted when the Crohn disease activity index is less than 150. And response in Crohn disease after treatment is defined as a decrease in Crohn disease activity index more than or equal to 100 points. Relapse for the purpose of clinical trial is when the Crohn disease activity index is more than 150 with an increase of more than 70 points from the baseline, and the relapses may be called infrequent if it is less than equal to 1 per year, and frequent if it is more than 2 or equal to 2 per year, or continuous if the patient has a persistent symptoms of active Crohn disease without a period of remission. The Crohn disease is called steroid refractory if patient is having active disease despite prednisolone up to 1 mg per kg per day for a period of 4 weeks. Patients who are either unable to reduce steroids below the equivalent of prednisolone 10 mg per day or budesonide below 3 mg per day within 3 months of starting steroids without recurrent active disease, or patients who have a relapse within 3 minutes of stopping steroids, they are called steroid dependent disease. The term recurrence in Crohn disease is best used to define the reappearance of lesion after surgical resection, and relapse refers to the reappearance of symptoms as above after the treatment. Another term in Crohn disease will be localized or extensive Crohn disease. It will be called as a localized Crohn disease if the intestinal Crohn disease is affecting less than 30 cm of the bowel length. This usually applies to the ileocecal location, that is less than 30 cm of ileum and the right colon is involved, but could apply to the isolated colonic disease or conceivably to proximal small intestinal disease. That means if less than 30 cm bowel length is involved, it will be called as a localized Crohn disease. Another term used is extensive Crohn disease when the length of bowel involved is more than 100 cm in whatever the location, and this applies to the sum of inflammation in discontinuous segments. That means if the part of the colon, part of the ileum and part of the jejunum involved and total length involved is more than 100 centimeter, it will be labeled as extensive Crohn disease. There is a gray area with no clarity in the description on any consensus guidelines, that is between 30 and 100 centimeter, and this length is arbitrary and we don't know where to place that patient in localized disease or extensive disease. The clinical features of Crohn disease are chronic diarrhea, and it is the most common presenting symptom. That patient will present with long-standing diarrhea of months duration, that may be 4 to 6 months or longer. A decrease in fecal consistency of more than 6 weeks may be an adequate symptom to differentiate this from self-limited or infectious diarrhea. This I have talked in my previous video also in ulcerative colitis, that any diarrhea which is persisting beyond more than 6 weeks should not be considered as infective diarrhea, and we should think on the lines of inflammatory bowel disease. Acute terminal ileal Crohn disease may be mistaken for acute appendicitis, and that becomes one of the differential diagnoses of acute appendicitis, that is the ileal involvement in Crohn disease. Chronic non-specific symptoms in children mimicking irritable bowel syndrome, that is IBS, like unexplained anemia and growth failure, should also be considered to avoid delayed diagnosis in children. Other features of Crohn disease are abdominal pain, which is seen in up to 80% of patients, unexplained weight loss in 60% of the patient, blood and mucus in the stool may be seen in up to 40 to 50% of patients with Crohn's colitis, but less frequent than in ulcerative colitis, in which the bloody diarrhea or mucus is seen in up to 80 to 90% of cases. The perineal fistulas are present in 4 to 10% of the patient at the time of diagnosis and may be a presenting complaint. So any patient with recurrent complex fistulas, we should keep in mind the differential diagnosis of Crohn disease. In a suspected case of Crohn disease, a full history should include the detailed questioning regarding the onset of symptom, recent travel history to rule out infectious diarrhea or amoebic colitis, food intolerance and medications, the history of appendicectomy and the age at the time of appendicectomy. The particular attention should be given to the well-proven risk for Crohn disease like smoking, family history of inflammatory bowel disease, and recent infectious gastroenteritis, which may flare up the inflammatory bowel disease. Careful questioning about the nocturnal symptoms. As I said before also, the nocturnal symptoms should not be there in case of irritable bowel syndrome, and if they are more in the night time, we should think on the line of inflammatory bowel disease and Crohn disease. The feature of extra-intestinal manifestation involving the mouth, skin, eye or joints, episode of perineal abscess or anal fissure should be inquired in detail in a suspected case of Crohn disease. The nocturnal symptom in Crohn disease are flare-ups at the night, pain in abdomen, frequent visit to the bathroom, which all disturb the sleep at night, and that lack of sleep could also make Crohn disease worse. The extra-intestinal manifestation in Crohn disease, they are categorized in two groups. One which is related to the disease activity, that means they are more severe. If the disease is more severe, that are erythema nodosum seen in 5 to 10% of cases, conjunctivitis 3 to 10%, acute arthropathy 6 to 12, and after ulceration in 10%. Other extra-intestinal manifestations which are not related to disease activity are sacroiliitis in 10 to 15% of cases, ankylosing spondylitis 1 to 2%, primary sclerosing cholangitis, which is rare and common in ulcerative colitis, gallstone in 15 to 30%, and renal calculi in 5 to 10% of cases. So coming back to our case, that we have a 38-year-old male with the recurrent history of subacute intestinal obstruction and chronic diarrhea, pain in abdomen, unexplained weight loss with nocturnal symptoms and diarrhea of long duration for 4 to 5 months. We have a clinical diagnosis of recurrent acute intestinal obstruction or subacute intestinal obstruction. The common differential diagnosis in a case of acute intestinal obstruction in decreasing order of frequency are adhesions, small intestine stricture which can be because of the TB, Crohn disease or ischemic, hernias, internal and external, intussusception, tumors which can be a cyst or adenocarcinoma, and worms. So we have a diagnosis of recurrent acute intestinal obstruction with chronic diarrhea in young male with these differential. So we have to work up our case and plan our management ahead. On evaluation of this patient, his routine workup including complete blood count, RFT, LFT, electrolytes were normal, biomarker was negative, and we asked for a X-ray abdomen, standing and spine. So for medical students and trainee, in any case of acute intestinal obstruction, X-ray abdomen, standing and spine are the basic investigation that we have to get in every patient. And the X-ray abdomen erect is for airflow level and spine is to characterize the bowel loop. On the right side of screen is X-ray abdomen standing, which is showing multiple airflow level in a step-ladder pattern, which is characteristic of small bowel obstruction. The bowel loop is considered dilated if the ileal diameter is more than 2.5 cm or jejunal diameter is more than 3 cm. And in the spine view, that is on the left side of screen, we can see with the rise tube in situ, there are bulbulae conventes, that is gives a concertina effect. We can see multiple loops, whitish bands, which are characteristic of the small bowel, that is of the jejunum. Another characteristic feature of small bowel obstruction is that in small bowel, the airflow level of the dilated bowel will occupy the central part of the abdomen. This X-ray abdomen, standing and spine is of a different patient, not related to the index case. For comparison, this is a case of large bowel obstruction where we can see that there are multiple airflow level which are towards the periphery, and step-ladder pattern is not there, and there are hostra which are more parallel and usually up to the 1/3 of the diameter of the bowel. We call it the bowel loop dilated if the cecum diameter is more than 8 cm or the colonic diameter is more than 5 cm. In the figure, in the X-ray on the left side, we can see large hostral loop of the transverse colon, and in the center part, as highlighted, is the small bowel loops because of the back pressure changes. So we can see the bulbulae conventes and hostra for comparison. These X-rays are not related to the case we are discussing. I have given only for the purpose of teaching to the graduates and postgraduate students. So now we have a radiological evidence of acute intestinal small bowel obstruction, and patient has shown some signs of improvement in the form of settlement of distension and passage of stool apparatus. So for reaching the diagnosis of this patient, but further workup you want, please think about it, write it down, and we'll discuss as the discussion evolves. The endoscopy and radiology are complementary diagnostic modality while investigating a case of Crohn disease. The Crohn disease may affect proximal small bowel, that is proximal jejunum, in 10% of the patient, which is out of the reach of the endoscope. The CT and MRI are current standard for assessing the small intestine. Both techniques can establish disease extension and activity based on bowel thickness and increased intravenous contrast enhancement. The magnitude of these changes, along with presence of edema and ulceration, allows categorization of disease severity. The CT MRI enterography has similar accuracy in detection of active Crohn disease in comparison with CT/MRI enteroclysis with NJ tube. So there are two terms. One is CT enterography, one is CT enteroclysis. So in CT enterography we give negative contrast in the form of say peg leg, and in enteroclysis, along with the contrast, we inject air with the help of endoscopically placed angiotube. It is an invasive procedure, so CT enterography is equally good and safer technique while assessing a case of Crohn disease and small bowel involvement. For confirming the diagnosis, we recommend ileocolonoscopy, or the literature recommends ileocolonoscopy with multiple biopsy, and it is a well established as a first line procedure for diagnosing the Crohn disease. The endoscopic hallmark for Crohn disease are patchy distributional inflammation with skip lesion. The Crohn disease ulcer tend to be longitudinal and may be associated with the cobblestone appearance of the ileum or colon, fissuras, orifices, and strictures. The rectal sparing is often encountered, while circumferential continuous inflammation is rare. The gastroduodenal involvement in Crohn disease is reported in only 2 to 4% of cases. So these are all the basis of question for super specialty examination like NEET super specialty or MCH examination, and these are all contrast feature as compared to the ulcerative colitis. In ulcerative colitis, the rectum is always involved. The inflammation is continuous, confluent, and concentric. There is 3C for UC. While in Crohn disease, it is patchy, linear, and skip lesion with cobblestoning, and there can be a rectal sparing. Fissuras are uncommon in ulcerative colitis and common in Crohn disease. The gastroduodenal involvement in Crohn disease is reported in 2 to 4% of cases, but never seen in ulcerative colitis. Coming to the classification of Crohn disease, there are basically three phenotypic types. One is inflammatory, another is fibrotic, that leads to fibrosis and stricture, and third type is fistulizing, which leads to fistulation that can be between the interbowel or other with like bladder, or small bowel, large bowel, etc. Within each of these subtypes, these may be mild to moderate, moderate to severe or refractory. Crohn disease has been classified by disease phenotype, that is the Montreal classification. We have to remember that Montreal classification also is given in case of ulcerative colitis. Disease activity index, that is CDAI, which we have already discussed, and response to the steroids, that is steroid refractory or steroid dependent. This is the Montreal classification for Crohn disease, and it has three variables. One is A, another is that is age at the onset, L location, and B behavior. So A1 is less than 16, A2 is 17 to 40, and A3 is when the age of onset is more than 40 years. L is for the location, L1 is when the disease is confined to terminal ileum, L2 when colon, L3 is ileocolon, L4 is upper GI. Or for example, if the disease involving the terminal ileum, then it will be L1 and plus upper GI, then we will add L1 plus L4. If it is colon plus upper GI, then it will be L2 and L4, and similarly L3 and L4 for ileocolon and upper GI. According to the behavior of the disease, it will be B1, that is non-stricturing, non-penetrating. The disease is simply inflammatory. If there is a perianal disease involvement, then we will add P to the behavior. If the disease is mainly stricturing type, there are multiple stricture or stricture formation, then it will be B2. Or if there is a fistula formation, then it will be B3, that is a penetrating type. If there is a involvement of the perineal area, that is a perineal abscess or the fistula, then we will add B1P. So if we have a patient whose age is say 38, then it will be A2. If the ileocolon region is involved, then it will be A2L3, and if it is stricturing type, so diagnosis will be A2 L3 and B2, A2 L3 B2. So that's how we give a diagnosis of the Crohn disease. There is a very limited role of serological testing, that's ASCA and ANCA, and they fail to differentiate between chronic and ulcerative disease, chronic CD and ulcerative colitis. And the new biomarkers, for instance, fecal volatile organic metabolites, could have a role in the future, but presently they have very limited role as far as the diagnosis or management of Crohn disease is concerned. The inflammatory marker, that is C-reactive protein CRP and fecal markers. They have a role in the diagnosis and management of inflammatory bowel disease. There is a good correlation between clinical and endoscopic disease activity and CRP level. That means that if CRP level are high, then disease activity or inflammation is high. The fecal concentration of calprotectin and lactoferrin they reflect migration of neutrophil through the inflamed bowel wall to the mucosa. That means when the neutrophil invade the bowel wall, the level of these fecal marker inflammation, that is calprotectin and lactoferrin, will be high, and increased fecal levels of calprotectin and lactoferrin reflects intestinal manipulation of any cause. That can be because of the infective or non-infective causes, that we have to understand. The meta-analysis demonstrated that normal calprotectin levels could exclude IBD with high accuracy, in particularly in adult patient. And in CD, calprotectin has a 90% positive predictive value for endoscopically active disease. To put in simple words, that means that in suspected cases of IBD, who is not on treatment, if the fecal calprotectin level are normal, then it will exclude the diagnosis of inflammatory bowel disease, that is Crohn disease or ulcerative colitis. And if these levels are high, then they have 90% positive predictive value. That means its inflammatory markers are high. That means the mucosa is inflamed and disease is active. Viewers, please remember the simple fact that if these inflammatory markers are not raised, then we should investigate that patient on the lines of irritable bowel syndrome, and that exclude the diagnosis of inflammatory bowel disease altogether. So I hope you have planned further workup for the index case of 40-year male with the chronic diarrhea and recurrent acute intestinal obstruction. So for any case of acute intestinal obstruction, the next investigation after X-ray will be a CCT abdomen. In the CCT abdomen, there was a 3 cm segment of reduced caliber with mild circumferential mural thickening and mucosal enhancement involving the mid-eyelid loop with upstream dilatation. The dilated loop also shows mucosal enhancement over length of 15 cm with symmetrical thickening. Another segment of 3.8 cm length showing same changes in the terminal eyelid was also seen. There were non-necrotic subsegmental lymph nodes present in the mesentery. On CT, there was stricture with enhancement of the mucosa in CT, and there was 2 stricture with upstream dilatation. His fecal calprotectin were 560 mg per gram of stool, which was quite raised. So raised fecal calprotectin, I am repeating, signifies inflammation of the mucosa and rules out the irritable bowel syndrome altogether. So that means we are dealing with the chronic diarrhea patient. So we have to think on the lines of inflammatory bowel disease at this point. So at this stage, now our diagnosis will be recurrent acute intestinal obstruction, 38-year male with stricture mid and terminal ileum, and the possible etiology is Crohn disease, TB, and the remote possibility of ischemic ulcer, although a good CT rules out the ischemia as ruled out in this patient, because there was a good enhancement of the mucosa, and in ischemic stricture the enhancement will be less. And in case of inflammatory bowel disease, it will be raised as was in this case. The common etiologies of small bowel obstruction in India are adhesion in 31% cases, stricture 27% of cases, hernias, internal or external hernias in 7% cases, malrotation and interception in 9% of the cases. The relevant reference I have given in this video. Please like and subscribe this video, and don't forget to hit the bell icon for future updates. The channel subscription is free for lifetime, and the knowledge is invaluable. The small bowel stricture causes are TB and Crohn disease in up to 60% of cases, The non-specific stricture 18%, no cause found in 20% of cases. Ischemic stricture 10% of cases, adenocarcinoma 8% of cases, eosinophilic enteritis 2.2 and neuroendocrine tumor in 1.1. So tuberculosis is the most common cause in India, while tuberculosis and Crohn disease combined is the 60% cases of a small intestinal stricture is the cause is tuberculosis and Crohn disease combined. In case of tuberculosis, pain abdomen, recurrent SIO and mass abdomen cocoon formation are common. Constitution symptom in the form of night sweat, evening rise of temperature, loss of appetite in another symptom, and they have extra abdominal or extra intestinal feature in the form of pulmonary coughs. Comb test is positive, and stricture is usually short segment, single, and pseudo circulation are rare. While in case of Crohn disease, the common presentation is chronic diarrhea, pain abdomen, bleeding PR, as I said, 40 to 50% cases, recurrent acute intestinal obstruction, and extra intestinal manifestation in the form of arthritis, uveitis, and erythema nodorum are more common, and Coombs test will be negative. The strictures can be multiple or single, and pseudo circulation can be seen. So to reach the clinical diagnosis and prove our diagnosis, what further workup you want for the index case? As I said, the ileocolonoscopy is the modality of choice for confirming or proving the diagnosis. So the colonoscopy in this case, they have seen the terminal ileum up to 30 centimeter. There were multiple erosion with one linear erosion, loss of basilar pattern, there was no spontaneous bleed, and rest of the colon, rectum and visualized mucosa were normal. They have taken multiple segmental biopsies. The upper GI endoscopy in this case and push endoscopy, in which we see the proximal part of genome, were normal. So there were involvement of the ileocolic region and with the form of multiple erosion and linear erosion was seen in this case. The biopsy taken during colonoscopy showed mild lymphonuclear cell invasion in the lamina propria with focal lymphoid follicle formation. So follicular formation was there. There were no granuloma seen or no amyloid deposition was seen, and no feature of dysplasia or malignancy. So at presentation, the Crohn disease will be B1, that is inflammatory only in 70 to 80% cases, B2 5 to 10% cases, that is stricturing type, and fistula type, penetrating type will be B3, will be 10 to 50% cases. The common site in Crohn disease is terminal ileum and ileocolic region, that will be like the index case will be L3, and it's a progressive disease, and at 10 years 50% change in phenotype and 20 to 30% becomes stenotic, and 50% requires surgery during lifelong. Out of which the patient requiring surgery, 70% patient will require second surgery for the complication of Crohn disease. So the medical therapies available for Crohn disease are steroids, which are used for the induction of remission in case of acute inflammation in the luminal disease, while they have no role in maintenance or remission or perineal disease or prevention of post-operative recurrence. The antibiotics has only role in case of perianal abscess and fistulas or post-operative period. Thiopurines has role for induction or remission, for maintenance or remission, perineal disease and post-operative to prevent the post-operative recurrence. Methotrexate again has some role for maintenance or remission. We don't have any data about the perineal disease or prevention of post-operative recurrence. The anti-TNF alpha, anti-tumor necrosis factor alpha, that are infliximab, adalimumab, they have recognized, I will say they have the anti-TNF alpha, that is anti-tumor necrosis factor alpha, include infliximab, adalimumab, certolizumab. They have revolutionized the treatment of Crohn disease, and they have got role in induction of remission, maintenance of remission, perineal disease and prevention of post-operative recurrence. Other options available are vedolizumab and ustekinumab, which we will discuss shortly. Coming to the medical management of Crohn disease, active Crohn disease, while starting the therapy or changing therapy, we should get a objective evidence of disease activity in the form of inflammatory markers, as that can be CRP, or more specifically fecal calprotectin, or colonoscopic evidence of inflammation and biopsy. In a Sonic trial, 18% of patients entered remission by receiving placebo only. Mildly active localized eosinophilic chronic disease, the oral budesonide is the preferred treatment, and meta-analysis confirmed that budesonide should be the preferred option and found no clear evidence of mesalazine being better than placebo at any dose. A recent trial suggests that some dose that is up to 800 mg per day of non-absorbable antibiotic rifaximin, that is a luminal antibiotic, could be better than placebo in inducing the remission of moderate Crohn disease. So there is some role of rifaximin in inducing the remission. The prednisolone is highly effective, but it has more common side effects than budesonide. So the preferred treatment for limited ileocolic disease will be budesonide, and we can add rifaximin, and if it's not responding or the disease is severe, we can start with prednisolone. As I said earlier, the anti-TNF, anti-tumor necrosis factor alpha monoclonal antibodies has changed the perspective or the management lines and revolutionized the treatment for Crohn disease. The first class to be introduced, most commonly prescribed, is anti-TNF monoclonal antibodies infliximab, adalimumab, and certolizumab. The additional biological therapies that are available, one is that target integrins, that is natalizumab and bidolizumab, or that target interleukins, interleukin 12 and 23, is ustekinumab. We have to remember some of these terms, and these can be the basis of question in our super specialty examination. The overall remission rates with biological is greater when administered to patient within 2 years of diagnosis. So if we are thinking on the lines of biologicals, we should start it early, preferably within 2 years of diagnosis. And 60% of patients experience recurrent symptoms after induced remission with anti-TNF alpha. So 40% patients will achieve a good rate of response and cure. So the biologicals has role in prevention. That is, if we start early, within 2 years of onset of diagnosis, they decrease the progression to stenosis in high risk groups, and it has role in treatment. With strictures with inflammatory component, they may reduce the need for surgical section in patient of Crohn disease stricture. For severely active localized ileocecal Crohn disease, systemic corticosteroid in the form of prednisolone or intravenous hydrocortisone is recommended. And for the patient who relapse after steroid treatment, the anti-TNF alpha, that is based studies as monoclonal antibodies, is appropriate. And surgery is a reasonable alternative for patients with disease refractory to conventional medical management, that is, the patient has failed after steroids or after the biologicals. The indication for surgery will be intestinal obstruction in 55% of cases, or intestinal fistula or abscess formation in 32% of the patients. So coming back to our index case, that is a 38-year-old male with a suspected or proven Crohn disease stricture in the ileal region, and our diagnosis was A2, L3 and B2 with recurrent acute intestinal obstruction, which improved after conservative management in the present admission. So we decided to continue with the conservative management and gave a trial of injectable methyl prednisolone so that patient can be saved from surgery. In this national cooperative Crohn disease study group, patients receiving 0.5 to 0.75 mg per kg per day of prednisolone, which was tapered over 17 weeks, 60% of patients remained in remission, while 30% patients in the placebo achieved remission. In the European Cooperative Crohn Disease Study Group, 83% of patients on 6-methylprednisolone of 1 mg per kg per day, tapered over 6 weeks, achieved remission, and 38% of the patient achieved remission in the placebo arm. So, for the chronic Crohn disease, there is a role of systemic corticosteroids such as prednisolone and its equivalent. Ileal release budesonide has no role because it is released in the ileum small bowel and doesn't reach the colon unless it is primarily affect the proximal colon. So ileal release budesonide may be effective for ileocolic disease but not for the chronic disease proper. The immunomodulators such as steroid sparing agents for those who have relapsed after the steroid like thiopurines or methotrexate may be employed. The use of sulfasalazine, metronidazole or nutritional therapy for adults with chronic Crohn disease has almost been consigned to the history. That means there is no role of these drugs, that's oral sulfasalazine, metronidazole or various nutritional adjunct available in the market. There is no evidence that mesalazine is effective for active Crohn disease. We have discussed that it is one of the best modality for ulcerative colitis but no role in Crohn disease. But opinion still varies about the value of topical mesalazine as adjunctive therapy in left-sided chronic Crohn disease, particularly in proctitis. That means if the Crohn disease is limited to the left side of colon, that is rectum, sigmoid or descending colon, then the enemas, that is sulfasalazine or mesalazine enema, may be employed as an adjunct but not as a primary therapy. There are 90% chances that ileocecal Crohn disease will require a surgery in a lifetime. The recurrent inflammation requiring another resection affects every second patient. Study at the Cleveland Clinic showed that disease of 10-year duration, 90% patient with ileocolitis and 70% patient with only ileal involvement required surgery. So we have to keep in mind that these patients and majority of these patients will require surgical intervention during their lifetime, and we have to counsel and guide our patient accordingly. For the localized ileal or ileocecal disease following resection, the long-term studies have demonstrated that there is 50% chance that patient will never require a further operation. That means if the disease is limited to the ileocolon or there is limited ileal disease and take out the whole involved bowel segment, then these 50% of patients, the half the population, will be cured, and that is a very good number. Long-term difference in the quality of life, medical or surgical therapy are not known, and we have to weigh the pros and cons, and we have to counsel and direct our patient. But as far as the surgical perspective is concerned, I will say if we can give them a curative section, it should be discussed and given a choice. Patient should be given a choice that we can achieve cure in 50% of patient, and that is a good number. While contemplating surgery in this patient, preoperative optimization is very essential, and we should consider TPN if patient is severely malnourished. Loss of more than 5% of body weight in 1 month or 10% in 6 months, BMI less than 19 and albumin level less than 3 gram per deciliter are all indication of preoperative optimization and TPN. Study of 395 malnourished patients who received 1 week of TPN before surgery showed a fewer complication as compared to control, and another meta-analysis of 18 study, the infliximab increased rate of post-operative complication, infectious complication, and reported to occur at a rate of 15 to 70% of cases. That means if patient is receiving infliximab or other monoclonal antibodies in the form of biologicals, then we have to explain to the patient that the risk of post-operative complication is high, and and we should counsel the patient accordingly. As far as the upper GI involvement in Crohn disease is concerned, 2 to 4% of cases will have contiguous involvement of antrum, pylorus and duodenal valve in Crohn disease. 18 patients, that will 40% of Lahey clinic patients had isolated duodenal disease with gastric sparing. 30 to 40% of gastroduodenal Crohn disease will require surgical intervention. That is again a very high number. Traditionally, gold standard for treating obstructing D1, D2 lesion was gastrogenostomy with highly selective bacectomy, but strictureplasty is a viable option, and we will discuss in the subsequent part of this video. Stricture in D2 and proximal D3, Henke Miculis is a good option. For D1 stricture, Jabule, that is between the greater curvature of stomach and D1, is another good viable option. For D4 stricture, Finne strictureplasty between D4 and first part of genome is a surgical option. So as I said, for D1 disease, Henke Miculis is option, and for small bowel stricture measuring up to 3 to 4 centimeter, this Miculis strictureplasty is a good option, in which we give a longitudinal incision and close it transversely. For Jabule gastrostomy, one D1 stricture is a good option, in which the first part of the genome is opposed to the stomach wall and we bypass the stricture. For long stricture up to 15 centimeter, Finne strictureplasty, as just demonstrated, is a option, and so we have to choose the strictureplasty according to the length of the stricture. For smaller strictures 3 to 4 centimeter, Henke Miculis. For longer stricture, Finne, and for duodenal D1 stricture, we have Jabule gastrostomy. This is another innovative technique for long segment stricture more than 20 centimeter. As I mentioned, up to 15-20 centimeter, Finne strictureplasty is the option. But for the longer stricture, Miculis strictureplasty is a good option reported, in which the isoperistaltic side-to-side strictureplasty is used to treat the long stricture or multiple strictures that are close to one another. The largest series of 184 patients across 6 international centers found the technique safe with 11% morbidity and 0% mortality, and effective with only 23% requiring reoperation at 5 years, and that is a good outcome. I have given the reference to this strictureplasty in this video, and viewers can go through this article to have a detailed or in-depth understanding of the technique. The fistulizing Crohn disease. Historically, Crohn disease fistula treated with bowel rest, TPN, proximal diversion, and occasionally resection. But the introduction of infliximab, that is anti-TNF alpha monoclonal antibody, changed the paradigm of operative indication. A recent study showed that a third of patients with extra-intestinal fistula achieved closure within 3 months of starting infliximab. Patient now undergo 3-month trial of infliximab prior to operation for fistulizing disease. So we have to remember this thing, that any patient with enterocortical fistula is not a surgical candidate, and we should give a choice of treating this patient with the with infliximab, and they have reported good outcomes. The enterointestinal fistula may not be clinically significant unless a large segment is bypassed, so they can be left as such, and should not be treated if they are not causing any nutritional issues. When an operation is undertaken, only one segment of the bowel is actively involved with Crohn disease, and other is a bystander and is not actively inflamed. So we should not resect the bystander or the innocent bowel segment which is forming a fistula, and the bowel segment which is inflamed should be taken out. So the actively inflamed segment of fistula should be resected, while the other can be repaired primarily. And we should try to conserve the as much as possible the bowel length that we can save, because most of these patients may require second surgery and they may end up with the short bowel syndrome. In an important study by Verse et al. Compared the strictureplasty to bypass, and mean follow-up for 8 years, and 1 out of 21 bypass patients required reoperation, while 1 out of 13 patient of strictureplasty, that is 7.7%, after mean follow-up 3.6 years, required reoperation, and that difference was not statistically significant. The authors concluded that despite short follow-up of strictureplasty afforded the same rates of symptom relief and reoperation and fewer complications, and strictureplasty has advantage of avoiding blind loop syndrome or stomach ulceration. So the replaced bypass operation or treatment was short obstructive duodenal Crohn disease. So we should not consider every time a bypass procedure, and the strictureplasty is a good option with equivalent and durable results. The most authors limit conventional strictureplasty to stricture less than 10 cm in genoidal Crohn disease, and the majority opinion that the strictureplasty is ill-advisable for longer strictures that are more than 10 cm. 10 cm. In meta-analysis, comparing conventional and non-conventional strictureplasties in 1616 Crohn patients who underwent 4538 strictureplasty showed similar results for both techniques, and the rates of small bowel obstruction, sepsis, reoperation, recurrence, carcinoma, and mortality were similar. A phlegmon in the bowel wall, carcinoma, or active bleeding with mucosal disease is a contraindication for the strictureplasty. So the question whether the resection of the involved segment will induce longer recurrence-free survival has not been resolved in the literature, and there are several case reports of adenocarcinoma at strictureplasty sites, rendering the need for caution regarding the long-term consequences of this procedure. So I will say that if we can resect the involved bowel segment without compromising the bowel length, or for we can avoid the short bowel syndrome, we should consider resection. And if there are multiple strictures and we cannot safely resect without compromising the bowel length, then we should consider strictureplasty. For example, in the index case, we have limited bowel involvement only, so we should be contemplating the resection only. After resection, what should be the anastomotic technique? In a meta-analysis of 8 comparative studies, including 2 RCTs, they compared end-to-end anastomosis with staple side-to-side anastomosis in 661 patients. End-to-end anastomosis after ileocolic section of Crohn disease was associated with increased anastomotic leak rates, and there was no significant difference in peri-anastomotic recurrence rate. Hence, in another trial, also meta-analysis comparing staple versus hands-on ileocolic anastomosis in 1125 patients, there was marked superiority of stapled side-to-side anastomosis. So, side-to-side stapled anastomosis is a better option, and there is no difference as far as the recurrence is concerned, but the perioperative complication rate is less. We have demonstrated in detail about the stapled side-to-side genostomy in another video tutorial, and viewers can go through that video tutorial to understand the techniques and the in details every steps of the side-to-side genostemy. As I said before, the terminal ileitis is one of the differential diagnosis, and if during routine exploration for acute appendicitis, if the surgeon finds terminal ileitis, it should not be routinely resected. If the patient has a history of obstructive symptom, or if the proximal intestine is dilated and the inflamed bowel wall looks typical of Crohn disease with mesenteric fat trapping, we should call a senior surgeon, and then the resection of this involved segment is justified. A population-based study has suggested a controversial association between appendectomy and subsequent diagnosis of Crohn disease, that increases chance of Crohn disease. But this association, if any, vanishes after 5 years. Coming to the role of laparoscopy, laparoscopic approach is justified and feasible and should be offered to patient if technicalities and the facilities are available, as it is safe and feasible in Crohn disease patient and have faster recovery and lesser complications. For short segment stricture which is endoscopically accessible, the endoscopic dilatation is an excellent approach, and it should be in the armamentarium of surgeons dealing with such kind of patients, as it saves the patient of unnecessary surgery. Renal Crohn disease is a unique phenotype associated with the earlier age of onset and more severe luminal disease. That means the perineal fistula indicates more severe disease. 30 to 70% inner involvement have minor skin tags to complex fistula. The initial drainage of any active infection or abscess and placement of ceton promote ongoing source control. Definite treatment of perineal disease is notoriously difficult. 1/5 of these patients will end up requiring protectomy and permanent endoleostomy. I have, as I said earlier, the introduction of infliximab and biological has led to a paradigm shift in the management of perineal fistula, and now they have shown a very good cure rate with the introduction of biologicals for perineal fistulas. Coming to the management of index case that we have been discussing in the 38-year-old male patient with the Crohn disease of the ileal stricture, with ileal stricture. Patient developed again recurrent obstruction, and we offered him surgery, and we did exploratory laparotomy with additional lysis and resection of the structure bearing ileal segment with endoleostomy and distal mucous fistula, as the proximal bowel was hugely dilated. The histopathological examination of the resected specimen showed extensive ulceration, transmural inflammation with muscularis propria hypertrophy, arterial thrombi in some mucosa, crypt abscess and distortion in the mucosa, where there was no granuloma, parasite or dysplasia. We have kept this patient on surveillance, and we will do surveillance colonoscopy after re-anastomosing the ileostomy and distal mucous fistula after 1 year. And the patient is doing fine on follow-up. So, what are the risk factors of post-operative recurrence? Smoking. If patient is smoking or continues to smoke, there is a 2.5 increased chances of post-operative recurrence. History of prior resection. The perforating disease or pressurizing disease is independent risk factor. A perineal fistula, as I said, indicates more severe nature of disease. Extensive small bowel dissection, more than 50 cm involved segment, then again it's a chance of post-operative recurrence. Formation of granulomas and myenteric plexitis is also a risk factor for post-operative recurrence. Thanks for watching, viewers. We hope we could add some new insight to your knowledge, and you will be able to manage Crohn disease patient more efficiently. Thanks for watching. Please like, subscribe and share. The channel subscription is free for life, and knowledge is invaluable. Thanks again. Happy learning.